Okay, I think we'll go ahead and get started, and people may continue to join. I want to thank everybody for joining today. Today's seminar is a little bit on a different day and time than some of our prior seminars, but we're super excited to have Dr. Andrew Ibrahim here to speak to us about redesigning healthcare delivery. Dr. Ibrahim is an assistant professor of surgery, architecture, and urban planning. So he has a very unique skill set, and he's also the co-director of the Center for Healthcare Outcomes and Policy. I know many of you have crossed paths with him through CHOP. He has been a member of IHPI, and his research is at the interface of healthcare, policy, education, and architecture. This has resulted in numerous publications, book chapters, international presentations, and his appointment to the editorial boards at both the Annals of Surgery and the JAMA Network. And I'm sure many of you have crossed paths with him in those roles as well. So like I said, we are extremely excited to have him speaking to us today, and I'm going to turn it over to him. I'll remind everybody that at the end, we will have our breakout sessions. For those that can stay, hang on, and Stacy will put you into a small breakout room, and we'll talk a little bit about today's presentation and get to meet each other just for a few minutes at the end. No pressure to do that though. And so with that, I will turn it over to you, Andrew, please.
Awesome. Well, thank you so much. This is super exciting. I was joking with Dr. Howley that I'm sure halfway through my slides, someone's going to say, oh yeah, I'm the world expert in that method that you've been trying to figure out for the last 2 years. That would be like the most Michigan thing ever. But I'm super excited and humbled that almost 50 of you decided to spend a discretionary hour of your afternoon with me. So I want to geek out with you about some of these interfaces of surgery, architecture, and urban planning, and kind of really just trade notes about what our group is up to and see how much it interfaces with all of you. A couple of my disclosures there. I won't talk about any of the architecture work that I actually do at my firm, and it'll kind of keep things more broad. If most of you, I think, probably know me in some form or another, but I sort of live in 3 different worlds. So I'm a general surgeon at the VA, and that's probably the core of my identity of being in the OR every Monday, a lot of Thursdays, and then on call every 5th week. A formerly trained health services researcher. So I did the RWJ program here at Michigan, spent a lot of time at my cubicle with both STATA code and then writing a lot of manuscripts that got a lot of red tape from a lot of red lines from Dr. Dimmick before being revised. And before I did all of that, I actually studied architecture. So I did my foundation coursework in London at the Bartlett, and then subsequently joined the American Institute of Architects Design Health Leadership Group nationally, and I spent about 3 years working in a firm as part of my appointment in the School of Architecture and Urban Planning here at Michigan, to sort of keep a hand in real world practice and understand what are the pressure points for the way we design the space we live in, and how does that actually relate to some of our healthcare outcomes. So at a high level, I'm going to try to hit like 3 domains of work that our group has really been pushing into that I think are some real opportunities to redesign the way we deliver healthcare. At the smallest level, it's at hospital design and the way that we actually organize our physical rooms and adjacencies, and how do patients do when they're put in one room versus another, and how do we develop frameworks and models to measure and understand that. Second is at a scale up of hospital networks. Since the Affordable Care Act, hospital mergers have more than doubled, and there's very rarely such a thing as an individual hospital, but we now have these networks of accumulated assets, and how do those get redesigned to optimize their performance? And then finally, at the largest level, thinking about neighborhoods and health, and how do the decisions we make in urban planning and design and how people's communities are zoned, how does that change the way they access care? And so I think there's opportunities at all 3. And what I'll try to do in each of these domains is tell you a little bit of the work we've done, some of the funding we're pursuing, and where we think the work's going. So I think all good research talks should start with like embarrassing phone call from your mom. So this is the day after I graduated medical school. Started getting all kinds of phone calls from family members asking for medical advice. And this one was from my mom, and she said, you know, Andrew, I've been getting this pain in my stomach. It's more on the right side. Happens about 20 or 30 minutes after meals, especially heavy, greasy stuff. And I said, oh, sounds like you need your gallbladder out. And she said, right, like that's what the doctor told me. And I remember pausing there for a minute. I hadn't hit July 1st yet and thinking like, 1 for 1 on clinical diagnosis here as a doctor. I'm feeling pretty good about this doctor thing. And the next question she asked me really threw me for a loop. She said, but where should I have my operation? And my mom at the time lived kind of out in the suburbs of Cleveland, and I went to school in Cleveland. And in just that 30-minute drive across town, there were 9 inpatient hospitals that she could go to for her care. And I kind of thought like, how would you know if you had to have surgery, where would you go? It's kind of an unsettling question the more you start to think about it. So this was some of our work when I was a fellow looking at variation in complication rates at centers of excellence. So these are places that dot all the I's, cross all the T's, meet all the requirements, have some external visitor every year to make sure you're doing all the things right. And their rates of serious complications varied widely. And it really kind of made me concerned. But at the time, I didn't really have the health services toolkit yet. So I thought about it through the lens of what I knew, which was architecture and design. So I thought like, how are these spaces designed? Like, what's the best designed physical building? And there is some research in that space where people have started to look at, does it matter what room you get assigned to? This is a paper that some of you, especially in the ICU community, may have seen, published in Chest, where they looked at these 4 particular rooms in this ICU that did not have a direct line of sight from where the nurses were sitting. And they actually found that these rooms that were poorly visualized actually had higher mortality rates after doing all the risk adjustments for all the other patient level variables that should influence care. But the caveat to it was that it was really only for high acuity patients, and that for other patients, it didn't matter. But it did sort of plant this seed that actually like the physical room you're assigned to, even in the right unit, may actually change the care that you receive. That was probably the most recent paper in that space, but this by far is the landmark paper that I think most clinicians actually don't know about, but is mandatory reading in architecture. And it was published in Science back in 1983. The title of it is View Through a Window May Influence Recovery from Surgery. It was a retrospective review of 23 patients who underwent an open cholecystectomy. Those rooms there in the green had a beautiful view of nature and a nice vista out their window. And those in yellow actually just looked into a brick wall. Patients presumably were arbitrarily assigned, just kind of whenever a room to open, they were put in. And the researchers found that the patients who had a view of nature used less pain medication, complained less, and went home earlier. This paper has now been cited more than 5,000 times and is probably one of the most influential pieces of research that has influenced hospital architecture, and is largely why we get so many of these huge windows in the patient rooms that we design, largely influenced by this paper. Now, I think a lot of us, whether we're formally trained in health services research or not, would see some threats to validity of these findings. But nonetheless, it's sort of been super important in this space. So I think from a methods perspective, a lot of the work maybe hasn't gotten things all quite right, but they have started to ask the right questions about, does the design of the space really influence patient care? So these are some of the domains that have come up repeatedly as may having some signal to influencing care, including single versus double rooms, how far away you are from a nursing station, and whether or not there's a window view and if there's a direct line of sight. So we've started to sort of translate some of those questions and ideas through the lens of traditional Michigan Health Services research. So in this piece, we took Donna Bedian's structure, process, outcomes to start to ask, how would that model translate to evaluating the quality of design? And have started to sort of lay out metrics and a framework to try to do that. And this is a piece that we're underway, led by Mitch Mead, one of our research fellows, who's actually taken the floor plan of Michigan Medicine, This happens to be the 5th floor, but it replicates through many of our floors, and started to code all of those design features that people have thought mattered. Single versus double rooms, window view versus no window view, how far away you are from the main nursing station, whether or not there's a direct line of sight into your bed when you're walking by. And it turns out that when you put these together, you actually develop a really fascinating natural experiment about the random variation in hospital room design quality based on what room you get assigned. So in those yellow rooms, you'll see that there are some rooms that actually have all of these features, some that have a few, and some that have almost none. So in a way, the patient rooms are already stratified by room design quality. We can start to evaluate how much does that matter. So we have taken our floor plans and location of care that we've now coded by design features and started to link it into the Precision Health database and start to evaluate what are the patterns and do they stratify based on these room design features. So here's some of our initial findings. And the first is pretty validating to me that nursing knows design matters, because consistently these rooms that have the best design features seem to consistently get the sickest patients, and it reproduces itself on both A, B, and C portions of our floor. The rooms that have that are closest to the nursing station are prescribed more sleep aids at night. But the rooms that have the worst design quality, they don't get the sickest patients, but they seem to have the highest mortality in our hospital, even after risk adjusting for a lot of the things that we think should influence that. So we're excited about that, and we're sort of working through more of that data in different cohorts and starting to explore how that may link to our patient satisfaction data. Think about how much random variability there may be in our satisfaction scores that may be just attributable to the different design features of the rooms that patients are in. And then the safety events and ICU transfers and photo rescue. So this is a line of work that is still pretty new for us, but we're pretty excited about. And from, I think, the architecture perspective, fills a lot of knowledge gaps because the traditional tools of HSR haven't historically been applied in this space. So I think it's a pretty exciting line of work. My mom didn't care about the architecture of hospitals. So when I tried to make my case to decipher through these 7 or 8 hospitals, you know, she didn't want to travel across town. She actually wanted to go to the local hospital down the street from her hospital, and kind of very wisely said, when I need a big operation, I'll go across town. I actually didn't appreciate how wise that was until a lot later. After my mom, she had her surgery, she did well and recovered fine. I read this article by Amir Ghaffuri, who was a fellow at the time, in the New England Journal of Medicine, again demonstrating this variation in inpatient mortality across hospitals. And I just remember my gut kind of sinking, thinking, did my mom go to the wrong hospital? She fortunately had a good outcome, but was she exposed to unnecessary risk that I maybe could have prevented had I known which hospital was better than another? But as I read that paper closely, I realized that it was actually a specific subset of procedures that were high risk. They were procedures that had a mortality rate greater than 1%. I wouldn't say that I was a outstanding surgical intern, but I knew enough to know that a cholecystectomy should not have a mortality rate of 1%, and that it probably wasn't reflective of this cohort that was being studied. And sure enough, all of the papers that I found when I started reading through them that looked at these volume outcome relationships, in fact, all focused on complex high-risk procedures. And so I wanted to know, what about for the things that the surgeries like that my mom had to have done for common operations that millions of Americans have done every year? Is it safe to stay local, or is it worth traveling across town like we had commonly preached for a lot of other procedures? When I pitched this to Dr. Dimmick as a research question, I had initially framed it through the lens of hospital design. And I remember him a couple times saying, you know, Andrew, I'm not a hospital architect, but I do know a lot about scientific measurement of quality, and I do know about location of care. So we looked at critical access hospitals because they were a unique subset of hospitals that you could identify their locations. And they were also exposed to a unique federal subsidy. So in the late 1970s, Congress passed the Medicare Rural Flexibility Spending Program that identified these unique safety net hospitals as those that were less than 25 beds, more than 35 miles away from another hospital, and provided continuous care. On an annual budget for CMS, they received more than $9 billion in funding. So we looked at a common set of 4 surgical procedures and 1.6 Medicare beneficiaries undergoing them to ask, like, does it matter if you go to a critical access hospital or not? And the findings were pretty surprising. We actually found that for these common procedures, these small rural hospitals provide safe surgical care, which is a little counterintuitive. And I initially thought maybe I had the variables backwards, but sure enough, they do just fine. Now, they may provide the same or better outcomes, but for how much? If they're being highly subsidized, there may be a real value judgment about, is it worth it? It turns out they actually cost less too, because they have less overhead and lower facility fees, that even after you price standardize and risk adjust, they still cost less than other sites of care to do the same procedures. So we were pretty excited about that, and it got a lot of attention in the news. And I can say a little shout out to the IHBI Impact Accelerator and Kara Gavin, who really helped disseminate this work. Within 2 weeks, it was the 49th most shared article at JAMA, which means a couple different things. One, I got a lot of emails from the rural surgeons who said, Andrew, we're not health services researchers, but we always thought that we did a good job and we appreciate you standing up for us. Can you come to our national meeting and talk to us? And I said, of course. But the second set of emails came from investors. And they said, Andrew, you told us that these small rural hospitals provide safe surgical care at lower cost. That screams value to us. Do you think we should buy up these hospitals? And sure enough, when I went to the national rural meeting and gave my talk, first question, Andrew, great talk. We're getting a lot of calls from investors who want to buy our hospitals. Do you think we should be bought and join a larger network? And I said I didn't know, but it certainly was a researchable question. And what was interesting to me is they were really asking, not only is where is the value, but where is the value optimized when you start to form into a network? And could you strategically form relationships between large and small hospitals that you could subsequently optimize? So since the Affordable Care Act passed in 2010, the rates of hospital mergers has doubled. There's more than 2 a week. And hospitals have really started to form into these networks. And it raises a really interesting question of, are you better as a network than you are as an individual hospital? So I tried to explain this to my mom, and she's always curious. She's like, what are you doing now? Are you used to surgeon? I said, yeah, I'm also like a health services researcher. And she's kind of too cool for phone calls now. So it's usually a text message. We had this exchange and she said, hey, Andy, hey, mom, what's up? Aren't you a surgeon now? Yes. Right. I told my friends. And you're a health services researcher too. I said, great. Yes, I am. She goes, good, because they all need surgery. So you need to recommend a place for all of them. And I understood what she was saying, but it actually really well captured the challenge of a health services researcher to say that, look, this isn't about just my mom, who's one person, and finding a location of care for her. This is actually figuring out on scale, thinking about regional delivery of care. Where should everyone go? And are there ways to optimize that? So the design question for me changed a little bit from just thinking about now of a single hospital to how do you redesign and optimize network performance. So this is some of our initial quantitative assessment of hospital networks. And I'll take a minute to orient you to this figure. Across the horizontal axis are hospital networks. Each of those dots is an individual hospital. And if they are lined up in the same column, they are in the same network. This particular outcome is failure to rescue. So this is death after a complication in the hospital. And you'll see that some hospital networks have uniform high quality care. You could go to any one of those hospitals in that network and likely have a very similar outcome. Some hospital networks, however, are highly variable, that you may walk into a building that has the same name, the same letterhead, the same logo, doctors who wear the same white coats, and your outcomes could be drastically different. And the question to me is interesting is, okay, if you were in that red column, is there a way that you could systematically transform yourself to someone in the green column? Could you go from a large network that's highly variable and start to translate your work to uniform, high quality care? So we then dug into qualitative work to start identifying health systems that were actually trying to redesign their service lines and started to codify and identify some of these domains where we felt like people were making conscious and deliberate efforts to improve quality across their network. So this was our most recent RO1 that had an impact score of 10 on last submission that we're excited about, and hopefully will give us 4 good years of support to pursue this work further to really tease out who are the high performing networks and what's their secret sauce, what are they doing to improve their quality, and is any of that reproducible across other networks. So as we got into this network work and started talking to a lot of these health systems about, you're now on scale, you're now representing half of a state, some of these are multi-states, it was clear that the expectations of what it means to be a network have clearly changed. So this is from US News and World Report. When they started to think about this network question, they started to change their idea of what their metrics should measure. So they, in their iterations of their quality measures, said, rather than seeing an elite provider as a hospital contained within 4 walls, we envision a web of hospitals of varied sizes and functions within an ecosystem that are able to address population health management initiatives that benefit whole communities. Such a different way to think about how to rank a hospital. If instead of thinking about an individual hospital's performance, you're now going to start thinking about how does the network perform on scale and what is its responsibilities to a community. So there have been alternative payment models in this space, initially titled Accountable Health Communities, where it actually started to look at what are the domains of health outside of the hospital that we think hospitals should be responsible for. And I have to say, this slide always frustrates my architecture colleagues because these are the 5 domains that were outlined by the alternative payment model. If you had to think, who are the group of people that are experts and think about this space, architects and urban planners should be pretty gosh darn high on your list. And none of them were involved in this alternate payment model. And they said, but this is like our expertise. This is what we know. But this was really designed for clinician use. So the year after, National Academy of Medicine created a toolkit for how should clinicians, so people in the hospital, start to screen for and identify these variables in the community that may influence health. And so it was very clear that the alternate payment model was going to guide this through actual hospitals. It also got the attention of insurers. Now, almost every insurer in the United States has a robust housing portfolio and are investing in housing as a strategy to reach population health initiatives, and even investing in food access. So hospitals now and their collective organizations have started to identify food deserts and are starting to measure, what is the benefit to us in addressing challenges in food access, and does that have a measurable return to us? So what's interesting to me is that this is the growth of hospital networks, whether intentional or not, has actually forced healthcare systems to now think about their communities in ways they maybe wouldn't have been able to as a single hospital, but now that they have scale and regional presence, they're required to. So the American Institute of Architects, in parallel to this, started to say like, well, architects should start to speak to how does the physical environment influence health? And they identified these 6 domains. And in part, the rallying cry came from the US Surgeon General at the time, who came to the AIA in a very large event and said, architects are public health workers, and you should see your work that way. and that the things you design and build, you should think about how they influence the health of the public. And it is true to sort of the root virtues of architecture. Marcus Vitruvius, in kind of his seminal canons of what architects should focus on, even outline that they should be equipped with a knowledge of medicine to know whether or not the buildings they design are healthy. And so we often talk so much about we're spending too much on healthcare, but this really prompted a very different discussion about how are we spending the other 80%? Of all the things that we build and design outside of hospitals, how are we spending those? And is health a priority in the way we're doing that? And could we learn from some of the domains outlined in these payment models to move towards a health in all design? Similar to health in all policies that was passed more than a decade prior, could everything we build and design be done with health as a priority? So I, in my Chief Grand Rounds talk in the fall before COVID, naively gave this example. Imagine Michigan Stadium, kind of like the center of Ann Arbor. What if that space was designed in a way that instead of just being a sports venue, was actually a public resource used every day for health? And not that I anticipated a pandemic, but this image was so striking to see that actually it is a very valuable infrastructure resource that became the main hub for where vaccinations were delivered. And when I talked to my friends in architecture about it, none of them even flinched. And they said, of course, that's where your vaccinations happened. They said, what other building do you know of that you can feed and move 100,000 people in under an hour? Stadiums are uniquely designed to do that. And it's provocative to think should we be designing those spaces deliberately to be able to support the health of a community rather than just an entertainment venue? So this has moved a lot of our conversations further to thinking about what about community and place, and how do we think about the way our communities are designed from an urban planning perspective, and how does that influence the way people access health? So this is a book that was given to me by one of my mentees and stimulated a really interesting line of work. It's called The Color of Law, and it basically traces 1930s US housing policy, which was actually explicitly discriminatory. It zoned neighborhoods based on their racial profiles and categorized them as best, still desirable, declining, or hazardous. We probably most often hear about redlining, but it was in these 4 tiers, and it was almost entirely based on the minority status of your community. And it effectively was implemented by enforcing racial segregation through these codes, because when banks were giving their loans, they disproportionately gave loans to the housing areas that were determined to be the best by the homeowners loan corporation. And so even if you were living in a red line community, had adequate credit, were more than able to pay for the home, it was very difficult to get a loan. So the neighborhoods that were doing well got better, and those that weren't doing well did worse. So this has been challenged multiple times. The Fair Housing Act of 1968 was the most notable. However, enforcing it fairly has been super challenging, and that during the Obama administration, they passed legislation for affirming further fair housing, recognizing that just saying discriminating by race is illegal was not adequate. And then in the subsequent administration, all those initiatives were removed. So it's very telling that a lot of these urban planning housing decisions of the 1930s are actually still very present and very much shaping the way people form their communities and are able to live in their homes. And the mentee who led this work, Adrian Diaz, who was a fellow here at Michigan, started looking through a lot of the Federal Reserve work that identified many of the gaps in home ownership across these communities, not only persist, but actually widened since that time. And so it begged the question, what does that mean for surgical care? If you live in one of these neighborhoods that's systematically been discriminated against, does that change the way you access surgical care and the outcomes you have afterwards? So we took Medicare claims data and geospatially merged it onto historic maps of redlining to identify how did Medicare beneficiaries do living across these neighborhoods. And the story, unfortunately, is not surprising that the past still haunts us and that there is a very strong stepwise increase in mortality after many of our common procedures just based on the neighborhood that you live in, even after risk and reliability adjusting for many of the confounders that influence surgical care. So when we sent this to surgical journals to review, we got a lot of criticism saying, you're not really capturing a historic exposure, you're actually just getting at modern day deprivation, that those neighborhoods just aren't good now, and that's actually what you're capturing. So we did do a sensitivity analysis controlling for the area deprivation index of that neighborhood. And so even at a given area deprivation index, being in a neighborhood that's historically been discriminated against still puts you at a higher rate of mortality after many of our most common surgical procedures. So what makes me frustrated and optimistic about this work is that these housing policies that are now coming up on a century still haunt us. But it makes me optimistic that if we knew how to make better housing policy with positive impact, that could also last a century too. So we've started to identify other domains where policy, geography, and access to surgery matter. This is work led by another one of our fellows, Dr. Lucier, looking at Medicare beneficiaries living in health professional shortage areas. These are typically identified for primary care shortage areas, and surgeons have sort of been off the map. But it turns out it tells a pretty informative story that living in a health professional shortage area means you travel 3 times as far and twice the distance to undergo common procedures. This is appendectomy, cholecystectomy, and hernia repairs as a beneficiary. So this is pretty timely because there are a number of proposed policy legislations to identify surgeon shortage areas and try to think about ways that access would be improved. But it's pretty alarming to think that millions of Americans are traveling almost 3 times as far to get routine surgical care. So in true Michigan fashion, this has been sort of the basis for our most recent R01 submission to think about geography and space and where you live and how that affects the way you access surgical care, and thinking about, is it the number of providers that are there? Is it a workforce challenge? Is it an insurance incentive? Or is it other factors about the place you live that change that? So appreciate you taking a little tour of kind of the work that we've been thinking about. And I think there are these 3 opportunities where design and healthcare delivery interface at the initial, like the actual hospital space, scaling up to hospital networks, and then thinking about, as these networks grow to scale, how they engage with their neighborhoods. It does take a huge team, and I'm enormously grateful for all the people on this slide, and actually others who've been really essential to moving this work forward and championing it. So I intentionally tried to finish early because I want to spend some time kind of geeking out with so many of you and get your thoughts and feedback and reactions about the work and the plans we have to move it forward.
Great, thank you for a fascinating talk, Andrew. There's a couple of questions and a comment in the chat. If you want to take a look, or I can read them to you if you can't see them.
Oh yeah, I'll start going through there.
Yeah.
So I'll start with Dr. Krauser. I will say the office view, I'm currently squatting in Dr. Walji's office, and I am like a big believer of like the window view office. And so I think there's certainly face validity to this idea that like a window view is nice. What frustrates me in the hospital architecture world is I think a lot of that's been like overstated. So I didn't present the work here, but Mitch Mead also has really interesting work that like window view, no window view doesn't really change your length of stay or how much pain medication you get after you appropriately risk adjust for all the other things that influence that. And so I think there's a little over eagerness to oversell the benefit of a window. And I think applying our right tools can just help us have a more honest discussion about what that is. And maybe the benefit is different, but if we're going to start using clinical outcomes, we should measure it fairly. Dr. Burney brings up a great point that speaks to my soul. He says, I was involved in the design of the current hospital and can report that what we wanted was overruled by architects who knew better than clinicians. Let me do this if you don't mind, Dr. Burney. I won't do it. I have another slide deck. I actually just gave a talk at Dr. Mary Dixon Woods's institute in Cambridge about why hospital architecture does not have a quality improvement format. And I'll just say practically from being involved on both sides of this, the number of stakeholders involved in a hospital construction has just gotten enormous, that even the most well-intentioned architect who spends all this time with us, shadows the surgeons in the OR, goes to the ICU, does all these focus groups, solicits all these innovative ideas. Those ideas start there, but once the engineers get a hold of it, and then the city code people, and then a couple donors weigh in on what they want things to look like, it's really hard to maintain those initial ideas and to maintain the perspective of users. There have been efforts to try to continuously reinsert both the users and patients in the process longitudinally, so that when the code moves the doorway or changes the space, that the user perspective circulates back in and pushes back. But there's no question that what we ultimately end up building is often pretty far away from what the users request, and frankly creates like a lot of animosity, to the extent of, why did you even ask our opinion in the first place? If you weren't going to build what we told you to build, why did you waste my time for 3 days? And so it is a huge methodologic challenge of, how do you solicit that input appropriately? How do you apply it? And how do you maintain it with all the other constraints? So Dr. Burney, I'm sad to report that your observation is spot on and still a problem now. Jonathan So says, are there any short-term actions that you can recommend to payers as we think about how to build high-performing networks? I have a number of ideas about that. I think one is related to the idea of what is your measures to evaluate a network. So just for example, in some of our preliminary data, when we submitted that grant initially, one of the criticisms we got was that we didn't have enough patient-centered outcomes. So we started thinking about that more and said, well, when Cleveland Clinic buys out half the state of Ohio's hospitals and says everybody who needs a Whipple has to come to downtown Cleveland, that may improve mortality rates. But one of the trade-offs is that now a patient's driving 3 hours for care, and that may or may not mean that their family member comes with them or not. And so I think one of the blind spots of sort of optimizing these networks has been, what are the trade-offs? Like, what are the trade-offs that maybe aren't our traditional measures that need to be on our radar? So I think we need to think about thoughtful ways that we're going to measure a network in addition to our traditional 30-day outcomes of mortality and complication rates. And I think the corollary to that in thinking about, it's hard for me to think about hospital networks without thinking about infrastructure investments in hospitals, because we spend close to $48 billion a year in hospital construction. So every one of these new networks is probably also renovating or constructing. And there is no version of In architecture, we would call it a post-occupancy evaluation. So after you design or build a new building, after it's been occupied for a year, you go back and measure, did it work? Is it doing all the things that we thought it was going to do? We actually don't have standardized ways to do that are widely accepted. We don't have standardized measures to know, did the building perform the way it was supposed to? And there is no precedent for putting financial contracts at risk. So I personally would love to see that the next time a big health system builds a new tower or building, they say, here are 1-year measures that we want for this building, and we're going to hold 1 to 2% of the total contract at risk based on whether or not the building performs. I think that would go a long way to quickly develop a space of quality improvement in hospital design that would be very responsive.
There's another question coming through.
Dr. Krauser has a great question about, isn't the reason for so many mergers and therefore networks motivated by profit or basically control of referrals, so that the goal of forming the network is not necessarily the goal of improved quality and safety? So it depends whose literature you read and whose microphone is the loudest. So there's no question in the economics literature, they have some pretty good data identifying that when a region gets dominated by a single healthcare system, they drive up the prices and make more money. That's like probably pretty clear. But there is actually, but the healthcare systems would say that they're actually achieving these economies of scale, and that by doing more of these procedures, they're saving money in these other domains. That is a little hard to tease out because of the transparency of financing. But there is some very good data led by Dr. Hari Nathan that at least for cancer surgery, forming into a network does reduce mortality. And so the healthcare systems have been very adamant that they are improving quality of care delivery. And there hasn't been a lot of transparency around price and profit. So it's been hard to disentangle that. But there is a lot of criticism, including the SEC, who pretty actively blocks hospital mergers and consolidations, primarily based on the concern that you raised, Dr. Krauser, that they may not be improving quality at all, but they in fact are just driving up prices, which made for a really nice knowledge gap tension in our grant to say, this is why we have to figure it out. So you're right, that's kind of one of the unknowns. Dr. Newman asks, how do you recommend a lay person choose which hospital to get their surgery at which information is publicly available today? Great question. We just started looking at, the CMS star ratings certainly get thrown under the bus a lot, but we started to look at measures of like 30-day mortality after inpatient surgery. Turns out CMS star ratings actually do reflect that reasonably well. There's a lot of variation within each star, but on the whole, it actually does correlate reasonably well. So I think that's probably the best surrogate. And I think in part, it also matters for which procedure. So for high-risk surgery, I unfortunately think volume is still our best guidepost about the best place to get care. But I think it's important to acknowledge that for a lot of our lower risk operations like hernias and gallbladders, there may not be a benefit to traveling 3 hours across the state, and that staying local for your care is actually very appropriate. So it has a lot of trade-offs, but unfortunately, I think volume is still the best of our worst options.
Dr. Kerr is raising her hand. Eve?
Yeah, hi, I was typing too, but I think I'd, hey Andrew, how are you? So I have a question that follows a little bit on Kristen's question about clinician wellness, and that has to do with burnout, which is such a huge topic right now in terms of burnout, clinicians leaving the workforce. And I think, and you can speak better to this, that there is some evidence about, and this is more in the ambulatory setting, that the architecture and how teams are co-located and communication, and even how much walking you have to do, may decrease your the time that you spend on things that are non-clinically related. And to the extent that burnout is really an imbalance between the amount of work that people have and the resources to do that work, it would seem to me that planning and architecture of our space could have a strong impact on burnout. And if we made that connection, it might actually increase the resources, that people are willing to commit to improving our space where we work.
I love it. I love it so much. And principally, I'm a believer that the space we design certainly could inform our productivity and our ability to stay optimistic and excited about our work. I think the science of how to evaluate the impact of design is still really nascent. And I think a lot of the research produced to say these co-locations, these adjacencies, these window views, or these that, wouldn't even be close to the rigor that we're used to in health services research. And so I've just been like very cautiously nervous about endorsing the idea that we could design for an outcome. I principally support it. I just don't think we've gotten the methods there yet to really disentangle why a design may or may not improve an outcome. But I conceptually love it and want to help figure it out. But I'll frustratingly say from the practice side of just what happens in real architecture firms when they're talking to clients, I think there's a lot of fast and loose with research work and data, and that we're not as rigorous or thorough about how much that research should inform the design. So principally agree, yes. I think our methods still need to catch up.
Andrew, what do you think is the role of, with COVID and kind of building on Eve's question with wellness, telehealth, and the intersection of that with some of the things that you're talking about? Is there a role for design as we are having more telemedicine delivery, and what are your thoughts on that?
Yeah, the telehealth delivery, I think has Chad given his seminar yet, Ella Moodle?
Mm-hmm.
He's had a
while.
great,
yeah.
His work has been so timely in thinking about the evolution of telehealth. I think one way that I've been thinking about it is a little more of a continuum. And on one extreme is maybe the telehealth. The other is probably the big quaternary referral center. And then there's everything in between. And I think what's probably gotten a lot of attention or more higher yield is what some people have called either mini hospitals or micro hospitals, where you maybe have a 50-bed hospital that's not 1,000 beds, but it is optimized so that it can provide some pretty high intensity care with an ICU that's maybe telesupported and with a handful of specialists that can manage some higher level problems, and that you strategically locate those in a way that optimizes access. So I think there's actually, in our continuum spread, we're probably been building a little too much in the quaternary tower mode and probably need more emphasis in more decentralized, smaller facilities. And I think the technology actually enables us to do a lot more specialty care with less overhead. That's a lot more nimble, and certainly telehealth enables a lot of that. But I think from a actual built infrastructure space, we probably need to get away from these doubling down on big towers, which everyone in architecture world, when I say that, kind of laughs, and they said, everyone's been saying that long before you, kid. But I think we actually probably will be able to have an empirical model to actually say like, here's actually the way to optimize the way the geographic regional delivery of care should be done. Thinking about these volume outcome curves, thinking about where access is needed and optimizing that so that it actually gets informed with like evidence as opposed to kind of gestalts. Question here from Tapped Cleveland. I love the slide questions where we're spending too much on healthcare versus how much we spend outside the hospital. How can architects, hospital staff, and researchers begin to shift more thinking on the 80%? Ooh, I love it. I can send you an article and a talk that I gave about it. But I think one of the things that makes me very optimistic and excited about the potential of architecture and urban planning to influence health is that in many ways, architects and urban planners will do whatever the client says. So if as the client, Michigan Medicine or University of Michigan says, we want you to design this new green space or this new dorm building to reach these health outcomes, and we used our experts here at Michigan to say how they should be measured and validated. That's the name of the game if you want to win this contract. If more clients just said that's a requirement of winning this proposal, of winning this project, architects will figure out how to do it. And so I don't think the rate limiter on the architect urban planning side is like an eagerness or excitement to do it. If there's a client who wants to do it, we could. And so I think maybe one of our best nudges is getting clients to make that a requirement of the design, and then the architects will figure out how to do it. So if every architecture firm needs to hire 3 PhD analysts and 3 MPHs to understand tenets of public health, they'll do it if that's what's involved to win a contract. So I'm actually optimistic that if the clients made that the incentive, we could actually figure out and design to it. I got a private message here from Dr. Rawlings, who is our health and design fellow, who was reviewing abstracts for one of our big health and design meetings coming up in June. And there was specifically a question around how you can model the optimal location of different scales of hospital intensity and how to actually do that in a data-driven way. The flexible space. So Dr. Krauser brings up a really interesting question about that sometimes a lot of the laws and codes that we have actually prevent us from innovating. So there are, in architecture, in healthcare architecture, there's the F word, which is the Facility Guidelines Institute, the FGI. And it is very well-meaning, but essentially says that to design an ICU room has to meet these code requirements, this, and this, and in ER, this, and this. And it all comes, I think, from a good place. But over time, what's practically happened, the codes have become so cumbersome that many architects actually just apply for exemptions to say, like, actually, this level of code is like so unreasonable to try to accommodate. And we just want to accommodate like almost none of it, which kind of seems like ridiculous. So there is a little bit of an awakening that we are probably too deep in the red tape, and that prohibits us from being more flexible. But one of the interesting examples from COVID that is informative is that, you know, we were rapidly able to turn a lot of our hospital into an ICU outside of our traditional ICUs. And those were regular floor rooms that never would have met code to be an ICU otherwise. And it kind of begs the question of like, if we were able to do it when we needed it, then like, are we kind of overdoing it with the code? So I think there is like a whole line of work growing now from that natural experiment to say like, how much did it matter to have all these codes, and do we need to start stripping them away? So I'm hopeful that there'll be some type of distilling, kind of like we've had with the National Quality Forum with the NQF, to say, you know, 1 quality metric was good, 2 was good, 3 was good, 500 may not be quite right. And maybe we got to scale back to the 50 that really matter and prioritize those. So I think architecture is due for a similar awakening. Alex Holloway asked, should or can Michigan CQIs like MSQC include architecture, design, and network organization in their work? I would love, in the same way, once we here at Michigan sort of figure out our coding of hospital architecture and design and start to validate our methods for how to determine these design exposures, to do that across multiple hospitals. It's certainly not too challenging once we have a hospital blueprint and walk through the building to start to codify a lot of these design exposures. And if we could start to collect MSQC data where we start locating the patient's room of care and where they got their care, we could certainly scale and make that a lot more robust. And similar to our other CQIs, I guess there could conceivably be a hospital architecture CQI where everyone changed their best practice. I think one of the historical limitations to that idea was that, well, what do you want me to do? Rebuild my whole hospital because you decided that like my rooms aren't the right size? And I think the better response to that is to say like, well, your hospital has some rooms that do well for really sick patients and some that don't. And we actually just need to right size acuity to how sick your patient is. So how malleable a hospital is up for debate. And I don't think many people have enough insight to know. There sadly is no uniform database where you could look up the hospital blueprints of every hospital. Like there's no equivalent of like Medicare claims or NSQIP where you could just look at all this clinical data. We don't have a hospital equivalent yet. So at a start, that would probably be what we would need to start building out the structure of a CQI type mission. So many good questions. I'm super pumped about this. I'm like very flattered that people are like engaging in this and thinking pretty deeply about how to tackle some of these design questions. Gracie Trinidad asks, I'm optimistic about that too. I was training design health program here at UVM architecture, see similar programs at Texas and firms like HKS and IDEO. The program is particularly targeted towards designers who wanted healthcare hospital design angle with the Texas program, particularly targets med students. Yeah, I think there is some small momentum building to start integrating a lot more of the health and design work. So someone asked earlier about focusing on that 80% and the how do we think about health and kind of things outside of hospitals. So EDRA is one of our big national organizations that does research on the interface of the built environment. And their theme for this meeting this year is health in all design. The idea that everything we build in design can and should be influenced by health. I say it slightly selfishly because I pitched the idea and it was adopted. So that's cool. I'll just put that like in the chat, but I'm excited that there's like a critical mass brewing to think about this interface and take it to scale. And there's a lot of really incredible researchers at that meeting who really understand how to measure the built environment that I think a lot of us from the healthcare side need to spend some more time geeking out with and making sure that our expertise in measuring health and health outcomes starts to dovetail with their expertise in the built environment.